So, good evening. My name is Professor Pam Shaw. I'm Professor of Neurology at the University of Sheffield and Director of the Sheffield Institute for Translational Neuroscience. In the next 20 minutes, I would like to make the case that the study of mice has been beneficial, not detrimental, for therapy development for patients with ALS or motor neuron disease. So we've learned a lot in the last few years about genes that can cause ALS or motor neuron disease, and identification of those genes has allowed us to develop models in the laboratory. And these are cellular models, in vivo models, including mouse, rat, fruit fly, and zebrafish. But there is no perfect model of adult human motor neuron degeneration, and we always have to use those models carefully and intelligently and link them back to human biosamples that may be brain and spinal cord tissue, or these days allowing us to take skin cells, fibroblasts, and reprogram them into the relevant cells in the nervous system, so motor neurons themselves or the neighborhood glial cells. In terms of mouse models, in this presentation, I'm going to mainly focus on the SOD1 transgenic model, as this is the one that has been used most trying to develop new therapeutic approaches. I'll touch briefly on TDP43 and C9orf72 models. So the SOD1 G93A transgenic mouse model is the workhorse for translational neuroscience, aiming to identify new therapies for MND. These are the key disease stages. So the onset of symptoms tends to be at about 90 days, and the mouse reaches late stage disease about 30 days later. So it's a highly overexpressing model. It concertinas the disease into a relatively short time span. The first sign that the mouse is developing ALS is loss of this hind limb splaying reflex when the mouse is held by the tail. You can see here the changes in the paw prints of the mice as the disease progresses. So this little mouse model has been heavily criticized. There was a paper in Nature in 2008 saying that this mouse model really had been detrimental for therapy development, and there were various criticisms made, including small sample sizes in mouse studies, biological noise interpreted as positive therapeutic effects, treating the mice at a pre-symptomatic stage rather than the stage where treatment would be started in human patients, and non-translatable dosages, etc. So this is just an array of therapeutic trials in MND which highlight really the failed translation from the SOD1 mouse model. So of all these different therapies tested, really only riluzole has positively translated and had some effect, although modest, in the human disease. So these are some of the drugs: minocycline, ceftriaxone, celecoxib, dexpramipexole, which appeared positive in mouse models, but weren't effective in human trials. And I think I've highlighted some of these problems previously. So problems with study design, variable models on mixed genetic backgrounds, publication bias, the doses used when translating from mouse to man were not always logical. And we mustn't forget, we've expected a lot of this SOD1 transgenic mouse model. Only we've tested therapies in that mouse, applied them in human populations where only approximately 2% of patients will have a SOD1 mutation. And another problem is that at the moment, we don't have a good mouse model of sporadic MND. So we've done some work in Citran at the University of Sheffield, trying to iron out some of these problems with the mouse model. We've bred the mice onto a uniform genetic background, which makes the phenotype much more consistent, and we've identified measures of motor function or other biomarkers, including catwalk gait analysis, muscle volume by MRI scan, body weight, and so on. And we've worked out for each of those readouts how many mice per group you need for an adequately powered study. So if you really pay attention to detail, you do get reproducible pathological and behavioral landmarks in this mouse model at very defined disease stages. For example, you can pick up the decline in motor performance at round about 40 days. You can pick up the inflammatory infiltrate in the spinal cord at round about 60 days. You can pick up the stage where there's a 50% loss of motor neurons, and so on. So you can, with careful attention to detail, identify key reproducible milestones in this mouse model. And I think in terms of improving translation to man, we need to be very careful about the pharmacokinetic, pharmacodynamic relationships. Ideally, we should have clinically translatable readouts of efficacy, developing novel biomarkers of target engagement, and validated against the standard of care, i.e. riluzole. And here are just some of the translatable readouts that we've been working on. So this is CMAP, compound muscle action potential, which you can measure in mice and also can measure easily in man. This is a sophisticated way of looking at the pharmacokinetics, so looking at the amount of free drug in the nervous system, as well as the total levels of blood, measuring glutathione as a marker of oxidative stress, which can be done in both rodent models and in man. And we mustn't forget also that around the world, the genetic epidemiology of ALS differs a little bit. So, for example, in European populations, C9orf72 mutations are very common, and SOD1 mutations are there in up to 20% of familial cases, about 2% of sporadic cases, whereas in Asian populations, SOD1 mutations are much more common. So just to re-emphasize the point I made earlier, SOD1 mutations are found in about 20% of familial cases, but only 2% of MND as a whole. And the pathology is different. So most SOD1 ALS is a TDP43 proteinopathy, as shown here. SOD1, patients with SOD1 mutations do not have a TDP43 proteinopathy. They have proteinaceous inclusions, but they do not stain with an antibody to TDP43. They're called hyaline conglomerate inclusions. A little bit about some of the other mouse models. So TDP43, the Q331K, tends to be the most commonly used mice, and these mice do show pathological changes, widespread alterations in gene splicing, motor dysfunction, motor neuron and axon loss, but they don't show the TDP43 mislocalization, and the disease progression tends to plateau at about 10 months. So they have some features, but they're not an ideal model. The C9orf72 back transgenic mouse models that have been generated are still being worked on, really. And the problem is that the phenotype is variable and the mouse does not behave consistently in different laboratories, depending a little bit on the background being used. So no model is perfect for adult human ALS, and we always need to use the findings from these models intelligently, link them back to the clinical data, the pathological data, and the reprogrammed cellular data from human patients. But I think the SOD1 mouse model that I've talked about has played a major role in demonstrating the complexity of the ALS neurodegenerative disease mechanisms. So the reason this disease is difficult to treat is that when one amino acid in the SOD1 protein is altered, about a dozen different things go wrong, both within motor neurons and in the crosstalk with surrounding glial cells. And the SOD1 model has been instrumental in showing us that. I also think the SOD1 knockout models have been useful. They've shown us that we can knock out or knock down the level of the SOD1 protein in mice with relative impunity. So if you completely knock out SOD1, there are some changes that happen in the motor system as the mouse ages, but by and large, these are much less conspicuous than the changes that happen in the presence of a SOD1 mutation. And I would argue that using the SOD1 mouse model intelligently, so my colleague Mimoun Azouz first showed that if you knock down the SOD1 protein in the SOD1 mouse model, and he used this by injecting shRNAs in a viral vector, a lentiviral vector, that when injected into muscle would be retrogradely transported to the motor neurons. So he used that approach and showed dramatic delays in disease onset. So the treated mice are in the red curve here, and a dramatic improvement in survival. So that was proof of concept that if you lower the expression of the rogue mutant protein, you can get beneficial therapeutic effects. And this is a later study, this time using a self-complementary AAV9 viral vector to take the shRNA into the nervous system. And again, the treated mice in the red curve, so you can see a dramatic improvement in motor function, in body weight, and in survival. And the neurodistress score, which rose rapidly in the untreated control mice, didn't happen in the treated mice. And in that same study, we also showed that you could get a good lowering of the SOD1 protein in different parts of the nervous system, but also importantly in CSF. So a 63% lowering of the SOD1 protein in CSF, indicating that this could be a very good biomarker in human trials. And this video just shows you the mice. So this is an untreated mouse at 120 days. This is the litamate mouse that has been treated with the gene therapy, and you can see the difference. The treated mouse is running around looking fairly normal. And I think this approach has translated. So not using a viral vector, but using antisense oligonucleotides to lower the level of the SOD1 protein in patients with SOD1 mutations. And this is intrathecal injection of an antisense oligonucleotide that causes breakdown of the messenger RNA for SOD1 by RNase H. And where the results of the phase 1-2 study Using this approach has just been published. So it was a multiple ascending dose study in 4 cohorts. The highest dose, patients were treated with 100 milligrams of the ASO at monthly intervals. And I'll just very briefly show you the highlights of this study of 50 patients, a proportion of which had this highest dose. And at the highest 100 milligram dose, you can see there was a nice lowering of the SOD1 protein in CSF by 37%, but also importantly, the levels of the neurofilament levels in CSF came down in the patients treated on that highest 100 milligram dose. And the effect was most dramatic in those with rapidly progressive disease, shown by the shown in this chart at the bottom here. And exploratory efficacy results. Again, the orange lines depict the treated group versus the placebo group. Again, the ALS functional rating scale, measure of respiratory function, handheld dynamometry, measure of muscle strength, all looked very promising in the group treated over a 12-week period compared to controls. I would also argue that in another motor system disorder, spinal muscular atrophy, where this is autosomal recessive and there's a deficiency of the survival motor neuron protein, using mouse models in this condition has also been very beneficial. So again, Mimoun Azouz showed that replacing the missing protein with SMN gene replacement is efficacious, and this is patient fibroblasts, so showing that you can upregulate the level of that protein. The SMN delta 7 mouse model is a mouse model of spinal muscular atrophy. These mice normally die by 13 days of age, and using gene therapy to replace SMN, you get a dramatic improvement in survival of the treated mice. And again, this is translated through into human trials. So this is single dose gene replacement using an AAV vector to replace SMN. As of October of this year, over 600 patients have been treated through clinical trials, commercially, and through a managed access program. And very beneficial effects are seen, particularly in patients with type 1 spinal muscular atrophy, Verdnick-Hoffman disease, where patients would often die within 2 years. And another approach using, again, an antisense oligonucleotide to target a splice alteration and increase the level of the protein of the level of the SMN protein, also published in the New England Journal of Medicine, showing very positive effects. And that has now come through into a nice approved approach for SMN patients. So I would argue that when carefully and intelligently used, mouse models of motor neuron disease have translated effectively. And Spinraza, nusinersen, Zolgensma, the SMN gene replacement for SMA, and tofersen, the SOD1 gene silencing approach, are what I've just shown you. So in conclusion, I think effective use of animal models and mouse models of ALS-MND has provided useful target identification and proof of concept studies. We know the upstream genetic cause of MND in 70% of familial cases and about 15% of apparently sporadic cases. For selected genes, gene therapy approaches are really looking very promising for effective translation for human benefit. I think we have in the past expected too much from the SOD1 transgenic mouse model, whose pathophysiology applies to only 2% of human patients. I think switching the emphasis from predicting clinical efficacy with certainty in mouse models to defining pharmacology and defining and identifying translational biomarkers is the best approach. Patient-derived in vitro cellular models are now proving very valuable, but we still need in vivo studies to complement those. And I think a major challenge facing us currently is the lack of mouse models of sporadic ALS. Thank you very much for your attention.